Hay has worked as an intensive care nurse in Ireland, the UK, Australia, and the USA. She occupied the role of Director of Industrial Relations in the INMO from 2008 until 2018, when she was appointed General Secretary. As General Secretary, she has overall responsibility for the organisation, leading on INMO's advocacy on national nursing policy and through various public sector pay agreements. Phil is an elected member of the Executive Council of Ireland's Trade Union Federation, ICTU, co-chair of Ireland's Emergency Department Task Force, and Executive Council member of the European Federation of Nurses. While working abroad, and particularly in New York in the early 1990s, where she worked in a cancer and related diseases hospital, Phil encountered a growing awareness in the medical world of significant infectious diseases, specifically HIV. Phil's presentation title this morning is Facing the Perspective of Virus as a Permanent Feature of Working Life. Thank you, Phil.
Thank you, Regina. Good morning. And I'm just going to bring up my slides here. So as Regina said, the title of this short talk is Facing the Perspective of Virus as a Permanent Feature of Working Life in the Context of COVID-19. And I'm going to look at this particular issue from the perspective of the working person, and most particularly from the healthcare workers' perspective, and also give a brief overview of what the trade unions in Ireland have been negotiating with government in respect of worker safety. So the first, I suppose, visual change is that all healthcare workers now, and many workers, but most particularly healthcare workers, are wearing what's termed PPE, personal protective equipment. And this is what it looks like. So it's a full body cover, a suit. Also, if you see the picture on my left, probably your right, the virus enters the body by mucous membrane, so it's very important to cover the face, particularly the eyes, nose, and mouth. So depending on where you work, you wear a different grade of mask and eye protection. And some people also wear visors if the appropriate masks are not available, and shoe coverings and gloves, obviously. So the two people here on the right of my screen are in a testing center, and the left is a nurse about to start her shift. So the aims of this presentation, very briefly, will be just to give a brief overview of the collective trade union position, as I said, and then to look at, again, briefly, what is our capacity? How many beds do we have currently to cope with the increase if a second wave of the virus, which everybody anticipates will arrive? Protocol then for returning to work as the workplace opens, as more and more workplaces open. How is that controlled? How is that governed from the point of view of infection and public health? And we now have a central importance for our Health and Safety Authority, which is an independent statutory body with the sole purpose of ensuring the health and welfare of those that are at work. We have made submissions, the Irish Nurses and Midwives Organisation, we've made specific submissions to government about how we believe the health service must change and what that needs in order to provide for our citizens and those that live in our country in a more equitable way. And I'll just briefly run through those. And then I'll present some statistics on healthcare workers. And the biggest issue for us at the moment is the very high infection rates in Ireland amongst healthcare workers. And finally, I want to give you some testimonials so you hear from nurses themselves. And I have a few slides on that. So as I said, the Irish Congress of Trade Unions has a policy document which has been launched. It's titled No Going Back, and it examines the all of the social and economic aspects of living in Ireland, north and south, because Congress has a jurisdiction both north and south, and looks at pre-COVID, post-COVID, and the lessons that we should learn and the changes that we should introduce in order to have a better and fairer society. So these slides are just the introduction to that policy, but I would encourage you to have a look, if you have time, on the Congress website and look at the No Going Back policy document, which goes through all of the public services, but also societal changes that need to happen. And that includes health, as you see here, housing, early years care and education, and promotes that the state takes a greater responsibility in these areas. Education, collective bargaining for workers' rights, again, a big issue, continues to be a big issue to ensure that workers have a say in how the return to work protocols are introduced, but also in general terms, that workers have greater say and that their trade unions can represent them and have the right to be represented. Social welfare benefits, again, we look at the rates of the COVID payments versus what people were earning on unemployment benefits and the lessons we learn from that. We also have proposals on climate action, international solidarity, and how you pay for it, what taxation systems, what the changes are in order to pay for what is proposed to make our society a fairer society. So that's the introduction to that particular policy and a very brief overview of the topics that are covered. From the point of view of the health service, the HSE and the health surveillance group publish twice, 3 times a week the available beds that are on every day available in order to ensure that we can assess the need and whether or not we need to look elsewhere, for example, into the private hospitals for critical care beds and general admission beds. So at the moment, this is the figure that has been published on the 3rd of June, and it shows that there were 735 vacant general beds in the country at that time, which is incredibly good, because, as you know, our hospitals have always been over 100% occupied, which we have been very critical of. And at that time, 103 intensive care beds were also available. Now, the intensive care beds, when you look at the small print at the bottom of that slide, they are inclusive of some private hospitals. So the Blackrock Clinic and the Mater Private, the Beacon and the Galway Clinic are included in those figures. So for the moment, we seem to be maintaining our capacity. Our numbers of admissions to hospitals due to COVID-19 have reduced, and also our intensive care utilization of beds is holding, and that is really good. Our discharge from intensive care units, very impressive. So people who have COVID-19 and are admitted to intensive care, many of them are being discharged, and the percentage is just over 70% at the moment, which is a really high figure. We monitor on a daily basis, and have been doing so for well over a decade, the number of people who are admitted to hospital, but for whom there are no beds. We use this as a measurement to determine capacity in our hospitals. And I've just put here a comparison between this very week last year, just to show the difference. So last year, in 2019, there were just over 385 people on trolleys on the first day of the week. And this year, on the same day, 94 people on trolleys. So that's a 76% reduction. And obviously, we believe that the trolley count on Friday yesterday was 112, that that's too high in the context of having an infectious disease also in your hospital, and that has to be addressed. However, it is a marked improvement on last year, but in the context of the pandemic, we need to have 0 in that slot every day to ensure that we're not putting people at risk when they enter our acute hospitals. So in order to arrive at a position, we have joined with our colleagues in the Irish Association for Emergency Medicine. These are the doctors who work in the emergency departments, and we've issued a statement to government, and we've continued to pursue this objective of having 0 patients on trolleys in hospitals, because it's simply too dangerous right now. So our statement calls for emergency measures to make sure that hospital wards and emergency departments do not become reservoirs of healthcare acquired infections for patients, and that the zero tolerance approach is taken to trolleys on corridors and trolleys on wards, on corridors, on wards, which again becomes extremely difficult from an infectious control, always has been, but with the pandemic becomes even more so. And also that in an overcrowded environment, it's very, very difficult for staff to work and to maintain their own safety at work. And that is the employer's responsibility. Therefore, we're calling again for assurances and policies to be put in place to make sure that emergency departments and hospitals are safe places for workers to attend. The government have joined with the trade unions and also the employers' representatives, IBEC, and others to draw up and put in place a return to work safely protocol. This is the cover of that protocol, and it's available on the Department of Business, Enterprise and Innovation's website. The protocol's purpose is to support employers and workers to put measures in place to prevent the spread of COVID-19 in the workplace. So as our workplaces now this week and next week will start reopening, and more people will be congregating in workplaces, we have to make sure that this protocol is absolutely adhered to. And how we do that is the protocol provides for a COVID-19 worker representative in each workplace. And a COVID-19 workplace representative will now be required to be in place. The important point is that the Health and Safety Authority will also have some jurisdiction over the workplace representative, but also the COVID-19 representative in the workplace. So we will have scrutiny by the Health and Safety Authority. We hope that that is really, really visible and strong, because the important reopening of the economy must now be completely and utterly conscious of the public health advice and protection of workers as they re-enter the workplace. In the situation of healthcare, the workplace has always been open, and this policy and this protocol will apply to workplaces that have remained open, and now they must meet this standard to ensure that their workers are also safe and reduce the risk of COVID-19 to a minimum. Obviously, the protocol is really important, and the concentration of the trade unions has been on the role and function and authority that now will be provided for worker representatives. So we have drawn this is a brief synopsis of the role of the local workplace representative in the context of COVID-19 and with the assistance of the Health and Safety Authority. And again, it's simple stuff, but very, very important. Local workplace representatives must carry out, for example, daily inspections of the workplace using a prescribed checklist that is part of the policy that has been drawn up by government. And the employer should have a COVID-19 representative as well. And the best practice is that both would carry out the checklist jointly. And if there are areas of concern, well, the local workplace representative must then raise these, and the employer is obliged to address them. The healthcare demands that we as a trade union representing largely nurses and midwives have proposed are to do with nurses and midwives' terms and conditions, but also very much to do with their interest and their belief that our health service can do better for our patients and for those who are dependent on the public health service. And it is a feature of many of the submissions we've made to government that we also speak of the service as well as the worker condition. The big demand is the very good recommendations from Sláintecare, and to translate those into the current situation, we need more beds. We saw that during a very short period when we requisitioned the private hospitals, we had an increase to our bed capacity, which was a real safety net for the public health service in the event that our intensive care units became overwhelmed. And thankfully that didn't happen. But we have to make sure that that safety net remains, because we don't know the extent of a second wave if it comes. And if we look to other countries, there were second waves of the pandemic which compromised and challenged their healthcare services. So we're looking for a permanent increase in acute bed capacity in the short term. That means, as I said, maintaining the availability of the acute hospital service. Hospitals in Ireland traditionally have been occupied to a level that is well over 100%, which means that it is unsafe by very definition. And the WHO standard of safety and the best practice in areas where hospitals are occupied to a level of 83 to 85% is considered to be safe, considered to be a model that provides for better outcomes for patients, better working environments for staff. So therefore, that's what we're aiming for, 85% occupancy across our hospitals. And we know that we now have a situation where healthcare workers themselves are getting sick. So we need to have plans in place to replace workers who are needed, essential healthcare workers, because the high rate of infection among healthcare workers requires them to then self-isolate for 14 days, and that reduces the availability of workers. We know that we're going to have additional workers available to work outside of our general hospitals and in areas which we are now developing to assist and to prevent admission to hospital. That's good, we welcome that, but we have to have a workforce plan to make sure we can staff these areas. Therefore, one of the big demands is that the recruitment embargo that applied in Ireland since May, which directly affected the ability to recruit nurses and doctors, that should simply just not apply. There should be an absolute agreement and statement from government that whatever else happens, we will not embargo the recruitment of nurses and doctors, because nurses and doctors around the world are now a very scarce commodity. And we also have the double problem of we rely heavily on recruitment from non-EU countries to supplement our domestic workforce. So, for example, in Ireland, we would recruit many nurses from the Philippines, from India every year. And up to this month, in the normal times, we would have recruited over 1,000. But because of the travel restrictions, that's not happening. So therefore, we are going to have difficulty in staffing new areas of work. And we need to make sure we have a plan and we think ahead. And we also need to make sure that PPE remains available in order to put maximum protections in place when we go to work in our health service. Again, we believe that the current moves which have moved and reduced the attendance at emergency departments must now be examined. We must examine what's causing, as well, obviously, as a general fear of attending hospital because of the risk of cross-infection. There are other stories and sub-stories to that. The drop in the trolley count would indicate that there are many people who are not attending, who are finding another way of getting their health care issue addressed, which is higher attendance at GPs, and also the community long-term care facilities providing expanded roles for nurses and also other healthcare workers to prevent the need to move the patient to the emergency department, which is the right route in our view. We have to expand the roles and functions of our healthcare workers in the long-term care facilities to ensure that they can provide the best service. We have many agreements over many years which would allow nurses, for example, prescribe, would allow nurses make decisions in respect of hydration, in respect of medication management, but unfortunately the policy doesn't exist. The agreement is there, the education is there, but the policy doesn't allow. We need to move there. We need to ensure that the long-term care facilities are not as reliant on the acute hospital as they have been, and that the expertise that is needed within the medical and nursing community is available to them on site when they need it. Community intervention teams are another very good preventative measure for hospital attendance and also hospital avoidance. And again, came up trumps during the pandemic, providing care in the home. And that's a 24/7 service. And the problem with it is it doesn't cover the entire country. These teams are nursing-led teams, and they are in place in 10 regions of the country. We need to expand them. They need to be rolled out throughout the country in order to maximize the care, the outside hospital care. Again, hubs, diagnostic hubs were created and are running in some locations during the pandemic, looking at testing, looking at triaging patients pre-admission to hospital. It would be an absolute shame if these hubs were not continued after the emergency crisis created by the pandemic, because clearly there is a place for pre-hospital triage and step-down recovery rehabilitation. And of course, the big problem is going to be finding staff to staff these areas, but it is really important that we look at what worked well and adopt it and continue with it. Renewed commitment, obviously, to the single public health service, which means that you have access to a hospital bed and hospital care, or indeed community care when and if you need it, and that is at no cost to the user. And that is the cornerstone of the Sláintecare report, which we believe can and is now a reality and must be reinforced and funded. Care of the older person services got a lot of scrutiny, still is getting a lot of scrutiny during the pandemic. We have been very critical of the outsourcing of the care of the older person to the private sector. 82% of all care of the older person is provided in private organisations. Some, the majority, are for profit, some are charities. But in the main, the connection between the public health service and the private provider is tenuous at best. And we saw that, and we saw what happened when the pandemic hit the care of the older person services. It's our view that the care of the older person services should be provided by the state, and that policies and procedures must now change to ensure that insourcing of the services that were outsourced occurs. We were critical of the HSE's plan. Their service plan in December 2019 suggested and proposed that a further 220 care of the older person public service beds would be removed during the calendar year of 2020. We actually believe that that's the wrong way to go, that we in fact should be adding to our public stock of care of the older person's services. And obviously the health service is funded on an annual basis, and we believe that that needs to change, and we've made submissions to government on this, that you can't really plan how you're going to grow and develop your health service when you're confined to an annual budget and you're constantly looking at your overspend, as opposed to how you develop for the longer term, invest now and then look at how that will pay dividend in the long term. Impossible to do that on an annual budgeting basis, but a great opposition to multi-annual budgeting for the health service in government. And hopefully we now will see the benefit of doing that, and long-term investing will become one of the positives out of this horrible crisis we're currently in with the pandemic. So just a brief overview then of nursing and midwifery staffing. How many nurses work in Ireland and how many do we train is always an issue that is of concern to us. We currently train about 1,800 nurses across 5 disciplines every year. The good news is that school leavers indicate on their CAO application, well, up to last year they did, over 5,000 Leaving Cert students put nursing and midwifery as their first preference. So that tells us that there are more people interested than places available. And therefore, what we advocate is that we should increase the undergraduate training places in order to build our workforce. Across the European Union, our colleagues in the European Nurses Federation tell us that there is now some indication that more people are interested in becoming healthcare workers, and the requests for information on how to train as a nurse have increased, which is good. And I think the positive contribution nurses and midwives and other healthcare workers are making during this pandemic means that people may very well be attracted to work in these roles, and that would be good. We have a limitation in our places. We should increase it, and that will help. As I said earlier, 49% of all nurses who registered in Ireland last year with the Nursing and Midwifery Board were non-EU. And the majority came from India, and the majority of our Indian nurses come from the province of Kerala, and they make up a large portion now of all of our hospital and care of the older person services. And the other large group are from the Philippines. And we also have nurses working in Ireland from Nigeria and from some of the European countries. Polish nurses and Italian midwives would be also the ethnic groups that now form part of the nursing and midwifery family in Ireland. We believe that immigration and travel arrangements for overseas nurses must take into account how essential these workers are to maintaining our health service and maintaining our staffing levels. And therefore, we have to look at ensuring that we can continue to recruit and continue to provide employment here for nurses who are willing and interested in migrating to Ireland. Also, I'm just giving very briefly at the bottom of that slide the numbers of nurses and midwives who were employed as whole-time equivalents in the public health service in December 2007, which was the date we always choose to compare our current figures to, because that was just before the first economic recession, or the previous economic recession, and we had 39,000 whole-time equivalents working in our health service, nurses and midwives at that time. And the figures that we now have, we still haven't got back to that. We have 38,824 last count in March, and of those, 1,000 were students in training. So really, you had 37,800. So we are running quite behind the figure that we should be at. And we know that our health service is now bigger, busier, and more acute than it was in 2007. The HSE produces a census every month, and I've just taken a snapshot of the grades. And healthcare workers make up 120,469 of all the workers in the country. That's how many work in the public health service, and they're broken into the various categories, and you see them there from consultant right through to nursing and therapy professions, home helps, healthcare assistants, right through. So that is, when we talk about healthcare worker, these are the workers we're talking about. So COVID-19 in the context of the healthcare workers is a public health risk, which obviously affects all citizens, but it also has a greater risk and a higher risk for workplaces, particularly the healthcare worker and their places of work. And I'm just going to briefly go through the worker protections that we're trying to put in place for healthcare workers. So at the moment, the pandemic is not classified as a grade 4 definition of the biological agent directive that is in place for all biological agents in the EU. COVID-19, it has been included since the 3rd of June as one of the definitions of what a biological agent is. However, it is not classified as the most dangerous. We believe this is wrong. There are 4 categories of risk in the biological agent directive, 4, as I said, being the highest. And the European Commission has determined that COVID-19 does not meet the definition of category 4. This matter is before the European Parliament next Thursday on the 11th, and it's before their employment committee. The definitions, category 3 and category 4. Category 3 is the definition that currently the European Commission has applied to COVID-19. And you can see there that it is defined as one that can cause severe human disease and present a serious hazard to workers. It may present a risk of spreading to the community, but there is usually effective prophylaxis or treatment available. Now, as everybody knows, there isn't prophylaxis available or treatment available for COVID-19 in the context of a vaccine. We believe that the definition should be one that causes severe human disease and is a serious hazard to workers. It may present a high risk of spreading to the community, and there is usually no effective prophylaxis or treatment available. And if that changes, the categorization of COVID-19 for the purpose of this directive can also change. So we've joined with our colleagues in the European trade unions and also the European Nurses Federation to lobby and to seek to have the categorization as category 4. That is very important, because then that directive would apply in all member states, and particularly in Ireland, where our own domestic health and safety legislation needs strengthening in respect of the protection it gives workers due to the categorization of the injury and occupational injury, which would apply in the case of an infection from COVID-19. So the Health and Safety Authority's definition and its function is to promote, encourage and foster the prevention of accidents, dangerous occurrences and personal injury at work in accordance with the relevant statutory provisions. So that's their function. We know that they're independent of workers, they're independent of employers, and they have specific requirements to ensure that when they inspect workplaces, that the employer's risk register determines that they are ensuring that the risk is at a minimum. In order to meet all of that, you have to make sure that the definition of what an accident is and what a personal injury is inclusive. We have now got a problem in respect of the definition of COVID-19 within the current HSA's definitions. So accident, you see here what the legislation says. It means an accident arising out of or in the course of employment, which in the case of a person carrying out work results in personal injuries. And a personal injury then is any injury, disease, disability occupational illness, or any impairment of physical or mental conditions, or if death occurs. They are all reportable incidences to the Health and Safety Authority, and that is a very important feature of their function. However, in the case of COVID-19, we meet resistance because albeit that the definition under the Act includes the occupational illness which may arise from a disease, a regulation under the HSA in 2016 defined the term personal injury as not including any disease, occupational illness, or any impairment of mental condition. So in our view, that's incorrect, and COVID-19 has to be included in the definition of a workplace injury or illness, and there are many arising. So we are now, in conjunction with the Irish Congress of Trade Unions, calling on the Minister for Business, Enterprise and Innovation, that's Heather Humphreys, to amend this regulation to expressly include COVID-19 in the definition of personal injury. And that is important because the numbers of healthcare workers who are now injured as a result of their work, we understand from a meeting we had yesterday with the HSE to be in the region of 60% of all healthcare workers who are infected are getting infected at work. So I'm just going to briefly give you an overview of the current healthcare worker infection rates. So at the moment, when we started, you might see on the extreme left of my screen, right of your screen, very faint, but that was the first week, the 1st to the 7th of March. There were 16 cases in total of people infected with COVID-19, and of those 2 were healthcare workers. And the 29th of March to the 4th of April, you see the rapid growth, which is 33% of healthcare workers making up the total number of cases. We get to the full month of March. Basically, we had just over 2,500 total number of cases, and of those 824 were healthcare workers. I just take a brief look at what the grades of healthcare workers were. So we know that of all of those healthcare workers infected at that time, between the 1st of March and the 11th of April, 883 were nurses, 35%. Other allied healthcare workers made up 25%, doctors, porters, healthcare assistants, and make up the remaining, with a category of unknown who didn't declare what their work was on the contact tracing. So we then look at that figure again, and we take it from the 1st of May right up to the 25th of May and right up to the 5th of June, which was yesterday. And we see that the numbers of infections in healthcare workers has risen dramatically. It's now just over 8,000, or 32% of the entire workforce. And as I said, we know from our meeting with the Health Service Executive and the Department of Health yesterday that 60% of the infections were acquired at work. So again, this is just a different view. So the blue is the total infection rates, and the orange is the total cases in healthcare workers. And the number of deaths among healthcare workers in Ireland is reported as 6. So our colleagues in the UK have been looking at the death of nurses, particularly in the Royal College of Nursing and other organisations. They've seen and they've been very concerned about the higher death rate among nurses from Asian countries. And Public Health England examined this issue of ethnicity and its influence. And it would appear that in Britain particularly, people from a Black ethnic group were more likely to be diagnosed with COVID-19 in general in the population, and death rates from COVID-19 were higher among people of Black and Asian ethnic group that translated into the workforce, and those from Asian countries had a higher rate of infection and also had higher death rates, which is very worrying. And we have asked our government to record these figures, to measure these figures, because if that is the case, we need to determine what's causing it and then put preventative measures in place. The largest absolute increase from Public Health England's review, which was just published this month in June, there were 760 deaths from all causes among workers in the caring and personal services in the period 21st of March to 8th of May 2020, and that was 346 more deaths than were recorded in the same period pre-COVID-19. So they're deducting from that 346 more deaths occurred in that category of worker, which increases the risk for healthcare and caring and personal services categories of workers. I'm nearly at the end, but I think one of the big issues for healthcare workers is obviously the infection rates, making sure they're safe, making sure we protect with PPE, and also find the cause for this increased infection rate to ensure that we can then put measures in place to prevent and to reduce the infection rate. Our members were very moved, I think, on International Nurses Day, which is celebrated worldwide on the 12th of May, by a statement from our president. And I just thought it would be worth repeating here. And I'm sure that the president holds the same sentiment for all healthcare workers. And I think his statement on the Late Late Show gave people a bounce, which helps to continue to go to work with a focus of caring when you know that you have the support of everybody in the country, and that what you do is viewed as being a very important element of beating this particular virus. So you can see for yourself what the president said, and we absolutely agree that we cannot forget the heroic efforts of healthcare workers and revert to the pre-pandemic position. And we would obviously say that that includes looking at pay rates for nurses and midwives who fall behind others in the healthcare worker professional family. Finally, then, I'm just going to give you a view of what healthcare workers themselves, what our members are saying, and what it feels like to be at work during this pandemic. And we have testimonials here from nurses who work throughout our hospital system and in our community. So this is Emma. She's an ED nurse. She works in the Mercy Hospital in Cork. And she is saying that I'm exhausted at the end of the day. Wearing a face mask all day is tiring, and the gowning up and the level of concentration needed to ensure that everything is put and taken off right in order to protect yourself and your colleagues is very tiring. I feel relieved when the day is done, another day that has passed, and we've all come out safely. This nurse works in the intensive care unit in St. James's Hospital in Dublin, and she said the biggest challenge at the moment is personal protective equipment. It's the very first time I've had to cover up in this way, and it's very frightening. It's difficult wearing a mask, and it's tight and well sealed. Of course, I know it has to be that way, but it makes it difficult to communicate with patients as they see you with a face shield and they're already scared. Thelma works in Our Lady of Lourdes in Drogheda, and she said there was a nervous mood in our unit initially, but once we educated ourselves and prepared as much as we could, things settled. The nursing team look out for each other, especially when putting on and taking off personal protective equipment. It's not about correcting anybody, it's about minding each other. And Danielle works in the ICU in Our Lady of Lourdes in Drogheda. You see here, this photograph includes the patient who's recovering and standing between the two healthcare workers, and they're clapping for the healthcare workers. But Danielle said that most ICU patients are very nervous when they arrive in ICU as they see us all gowned up. It must be so unsettling for them. My new favorite feeling is when I'm out of my PPE and after my shower in work, going across to the car park and taking a breath of fresh air and feeling it on my face. This is the final one. This is Anne-Marie. Anne-Marie works with persons with intellectual disability, and they were very late in getting PPE. The PPE was concentrated in the acute hospitals initially, and therefore they had to be very guarded with how they used it. So that's what she's saying. We had to be prudent in our use of PPE at the beginning, but we all wear masks now. The mask policy came in the HSE on the 22nd of April. We had been lobbying very hard and arguing that every healthcare worker should wear a mask in all settings. And that became the policy only on the 22nd of April. And we've seen actually that the infection rates among healthcare workers has reduced since that period. So wearing PPE affects our communications with service users. So our speech and language team worked on developing communication tools to help with this. So we all have our photographs taken in our PPE and in our normal clothes to help service users know who is who. So you can see here in the picture, the nurses have their photographs penned to the outside of their protective gowns. So finally, I'm just posing this. Somebody sent me this during the week and I thought it was a little bit funny. I hope you see the joke. So basically, what can you do? What can we all do to protect our service, to ensure that our service can cope, our health service can cope, and to ensure that our healthcare workers are safe? We can follow public health advice and ensure that infection rates in the community remain low and that the reproductive rate remains low. And that's really important, because if our services become overwhelmed, our healthcare workers will suffer to a very huge extent, and we can't have that happen. Thank you very much. I hope this has been some way helpful or informative, and I'm very happy to take any questions. Thanks, Regina.
Thank you very much, Phil. Yes, I have a number of questions that have come in.